Okay, while Sam is bringing it up, I'll introduce myself. I'm Michael Uhas. I am an advisor to the Path Forward, and that includes Path Forward national activity as well as Mid-Atlantic specifically. Sam, is there a slide before that one about there we go. Thank you. And so the Mid-Atlantic Path Forward is an affiliate of the National Path Forward. The Path Forward itself nationally is a coalition of organizations. I'll hit it more in a couple of minutes. But in the Mid-Atlantic, we're one of a number of regions, multiple regions, that try to help implement and act the activities and priorities that the Path Forward nationally is pursuing, which all pretty much relate to improving access to mental health and substance use care. So this particular series, we have been, as the Mid-Atlantic Path Forward, over the past few years, really working to educate the provider community, the payer community, the regulator community, the employer community, about a number of initiatives Path Forward is involved with, but specifically collaborative care. And as I had mentioned or we mentioned in the invites that went out, Maryland this year passed new legislation which enables the payment, the reimbursement for collaborative care codes under Medicaid. So it's one of nearly half of the states, I think 24, 25 we're up to now, that have passed such legislation. And we expect this to generate even more interest and be more of an impetus to see more collaborative care getting started in the state. So this particular series, we wanted to go through or past the pure educational mode and actually try to get into having case studies presented so that people can hear and have an opportunity to interact with folks who have set up programs, hear how they did it, what they went through, how the program is working, rather than hearing it translated all through us. So that's what was behind this particular series. We're planning on 3 sessions. This is the second of 3. The next will be the end of September. I'll hit that at the end. They're all from 12 to 1. They are all recorded sessions, and they will be shared via the Mid-Atlantic Path Forward website. If you look at that website now, you can see our July 28th presentation or session. Again, 2 presentations each session, 15, 20 minutes apiece with some Q&A following each. And we're trying to get organizations inside and outside of Maryland with different kinds of profiles, patient panel profiles, organizational profiles, specialty provider profiles. And once again, focus on sort of the reality of getting these programs up and running, sustainable and successful. And we wanted to do a quick shout out to organizations, foundations, and other entities that have helped us get this far. At the bottom of the screen, you can see the Open Society Institute of Baltimore, the Leonard and Helen Stolman Foundation, and Johnson & Johnson. Each of these organizations have helped contribute to our ability to do what we're doing now. And we thank them very much for that. Sam, if we can go to the next slide. Another few words around the Path Forward nationally. Again, it's a coalition that is backed by a number of very influential partners, which you'll see along the bottom of this slide. And its primary intent is to focus on a few very doable, evidence-based initiatives that can help most rapidly improve access to mental health substance use care and the quality of that care that's delivered. Next slide, Sam. I mentioned that we are one of a number of affiliates. You'll see on this screen, there are 8 of them that are sort of more officially recognized as what are called reset regions within the Path Forward. And there are also dozens of other healthcare purchaser coalitions around the country that also participate in Path Forward initiatives. But this gives you a sense of the kind of geographic scope of where we're trying to develop partnerships with implementation partners to help put some of this into action, which is what we're doing today in the Mid-Atlantic. Next slide, Sam. Just for level setting, we know and recognize there are a number of different ways that behavioral health care can be integrated into primary care, and we are big fans and supporters of doing that generally. But I want to make sure to clarify that what we're talking about in these series is specifically the collaborative care model that many on this call, if not all, will be familiar with, that came out of the AIM Center at the University of Washington, that really revolve around the basics of having the primary care provider maintain responsibility for treating the patient and have the evidence-based model supported by a behavioral health, one or more behavioral health care managers, psychiatric consultants, which are typically psychiatrists, but not always. And you'll hear in John's presentation this morning as well, that there are ways that a number of organizations have adapted with other professionals, not just using psychiatrists in that role, but they do have to be qualified to do that in order to be eligible for reimbursement. So that's the model we're talking about. And we're not interested in, disparaging any other model. We're happy to see integration occur, but this is the one that, like all path forward initiatives, brings the strongest evidence base to the table that we're very comfortable moving forward with and endorsing. So, Sam, next slide, please. So today we have two organizations presenting. John Parkhurst directs the Mood, Anxiety, and ADHD Collaborative Care Program at the Lurie's Children's Hospital of Chicago. You will have, in the invite that went out, you'll have links to bios for these folks. You don't have one for Dana, and you have an earlier version of John's. So we're going to correct that. When these things get posted on the website, there'll be more up-to-date information, but these are just the sketches. So John is going to talk about the program that he directs there that focuses on helping pediatric practices address the mental health needs of children and adolescents. So John will actually start us this morning. Then that'll be followed by a presentation from about MedFirst Primary and Urgent Care Organization in Raleigh, North Carolina. And Dana Wolf, who is the Director of Quality, will present along with Verna Little. Verna, some of you may know her outside of this particular presentation. Verna does a fair amount of work working with organizations around the country on collaborative care, and in fact, internationally in her consulting activity as well. So Verna and Dana will do the presentation of MedFirst program. So with that, I think we can turn it over to John. And again, 15, 20 minutes followed by a 5-minute Q&A. And if we have time left at the end, we'll add, some time for Q&A at the end. So John, I'll turn it over to you.
Great. Well, thank you for the opportunity. I'm assuming everybody can see me all right, because Michael, I just see you on my screen and in my slides. You're muted, Michael. Oh, there we go. Okay, great. Well, this is a very nice opportunity to highlight a program we've spent a lot of time working on. If you want to continue advancing, that'd be great. What I will present, so I have nothing to disclose. I will present some data that is currently under review for a journal, but it has all been IRB approved for retrospective review. Go ahead. I don't think we have to belabor the point that behavioral health is a huge need for us across the country. It costs a lot of money, and we are short in people that can provide care. And one of the best places that I think we all see as an opportunity is how do we work more effectively through our primary care spaces to be able to provide that care. Go ahead. So as Michael referenced, there are a number of models for providing behavioral health treatment within primary care settings. You'll see below here the levels of integration that were defined by SAMHSA. I think these are becoming quickly outdated, as there are many models that kind of have to respond to different and unique barriers. And just calling something coordinated or co-located or integrated, I think is insufficient. And probably mostly insufficient because many of the models that have developed, for example, integrated primary care, is a model that also talks about integration. So using the terminology, I think more broadly as coordinated and collaborative care, I think is important. But collaborative care is also its own specific model. So just some semantics that I think become challenging when we're thinking about primary care spaces. Go ahead. So other examples of collaborative care more broadly include child psychiatry access lines. We can talk about those if we need to. Many states have these. Next. Also Healthy Steps, which is focused on a younger population that does more integrated primary care, typically using and leveraging psychology to do behavioral or psychosocial interventions. It's the PCBH model, which also has some good evidence behind it. And then moving to collaborative care. Go ahead. And sorry, next one. Next, please. And then, thinking about collaborative care, this is the model that everybody here is interested in. I would make an argument that collaborative care, why there's more evidence for it, at least in the adult space, is because it's a little bit easier to study than some of the other models, just in terms of defining the specific model elements. But there are some core model elements that probably overlap all of collaborative care, specifically population-specific focused care, management of a population through the primary care provider as the central piece, and then measurement-based care. Go ahead. So this is Lurie Children's, but this is not really where we do the work. Our work is in primary care clinics, so you can go ahead. So we have at Lurie a little bit of a spectrum of collaborative care in the sense that we have resident clinics where we do training, where we've got more integrated staff. We've got social workers and psychiatry there. We also have a more specifically IPC model of care in 3 now primary care practices that are part of us. And we're able to do that model more effectively because they're part of us as far as a health system. But the program that we've developed and we'll talk about is the MAC program, which stands for Mood, Anxiety, ADHD Collaborative Care. And we've developed this model around responding to the needs of independent and small practices that are in our region. So that is its own little nuance because these are small businesses in effect. So trying to work as a health system to coordinate and collaborate with people that aren't necessarily sharing the same systems it provides a challenge, but it's also a really wonderful opportunity for growing, these service providers. So we know the challenge about primary care. They have very little time. They typically underdiagnose mental health conditions. Wait and see is still kind of the model of practice, but we need to kind of work on that. You can move ahead, please. So barriers or factors that will drive the implementation or use of specific models. So in my experience in primary care, there's limited understanding around the evidence-based practices with screening and detection, understanding of what good psychosocial treatments look like, understanding of good medication management practices. So I think, we're all interested in access to care because that's maybe has been the biggest need, especially during the pandemic. But something that doesn't get talked about often enough in parallel is quality. Because quality also drives the degree to which we are engaging or in service. Because if we can get a person into quality care, then they're hopefully less likely to re-engage in care or their treatment can be more expedited. So that needs to be a huge focus in this. Also, what is available in the community, I think, varies from practice to practice. And one of my favorite sayings, and I think it's always a truism, is that if you've been to one pediatric practice, you've been to one pediatric practice. Because there's such variability across the landscape, and still about 50%, a little under, of pediatric primary care providers are working in practices that have under 5 providers. There's a lot of small businesses out there. So where they are located, whether they're rural or urban, might dictate the types of resources that they have available. For example, types of therapy, access to medication management, linkages with hospitals, and we can keep going. And one of the other things that I think we knew when we were developing a program here to work with these small practices was that we had some initial funding to support through philanthropy to really develop out and support this group. We also have an integrated care network, or CIN, that has a large amount of practices that they're already working with that were interested in behavioral health. So we knew we had these two things. I will say that our model now is works outside of just the CIN, so it's not just exclusive to those practices. You can move forward, please. So we really started with like a logic model of what we wanted to achieve, and I'm not going to spend too much time on this. This is a paper we put together in 2021 about our program, looking at initial results. But we wanted to expand, looking at multiple diagnoses, expand services, looking at multiple diagnoses: ADHD, depression, anxiety, common concerns in primary care settings. We wanted to be able to provide timely access to resources, as that was a big need from our primary care providers. We did a needs assessment survey to help us drive these objectives. I'm kind of a measurement-based care person, and I really care about that because it's hard to know if something's getting better if you can't measure it. So we wanted to make sure our treatment was optimized. So we can move next. To really meet these goals, we saw collaborative care as probably being the best model that aligned with what our vision is, or our vision was, for these small practices. It was focused on a population. Measurement-based care is really targeting the idea of evidence-based treatment and providing that. And you can do the collaborative care model working in an off-site way. We weren't going to be able to go into all of these pediatric primary care practices and add a care manager or add a psychologist or a psychiatrist. So we really needed something that we could do as kind of a hub-spoke model, and collaborative care allowed for that. Something that I don't think is said often enough: collaborative care is a clinical program to drive clinical outcomes. But it really also is a training model. You don't see collaborative care often without a big training component behind it. So we developed online modules that we asked all of our providers that were going to engage with us to go through, and then also have a monthly learning collaborative that is similar to a REACH model, if some of you are familiar. We also saw that there was some value add, as Michael referenced before, in providing consultation from multiple types of providers, so psychology and psychiatry specifically, as there are different strengths across these disciplines. And I think a multidisciplinary approach is usually more effective than one discipline alone. So next slide, please. So how we developed our model, and it really is, it's not different than the Ames model. The only big difference is, well, there's two differences, I would say. So we've kind of combined a psychologist and a psychiatrist to put their heads together on all direct services. So it really is a hub-spoke model. So with the hub being the medical center, where we have the specialist and care coordination located, and the spokes being the independent primary care practices. Some of these practices were linked through our EHR because they're part of the CIN, some are not. So we use technology engaged platforms. So Proficient Health has a text messaging service that's secure, that we've leveraged for referrals and consultation with practices that aren't on our EHR. And then there's old school fax. So we really, and I'll talk about the structure of how we do the actual referral process. PCP is at the center. Care coordinators, behavioral health care managers really drive the whole process and keep everything coordinated on a registry. Psychologists do a lot of the evaluation, where psychiatrists add to the evaluation and do cross consultation. In the evaluation process for the people that are referred, they are receiving these evaluations back to them, but also they're really written for the PCP to help drive treatment recommendations. We also, in Chicago, because we recognize we have a lot of community resources, we have community therapists. And there's certainly variability in how they provide treatment, but we were able to cultivate our community therapists that we could leverage for when we needed psychosocial treatments that were closer to home or matched with insurance. Next, please. So what this would look like. So if a pediatric practice decided that they wanted to engage in our collaborative care program, they were expected to do the education modules and then engage in our monthly learning collaborative. Once they did the modules and did some of the training, they could refer if they had a patient that they felt like they needed further diagnostic clarification, wanted recommendations around psychosocial treatment, wanted recommendations around medication management. And so that we kind of use that as a model to actually see the patient and be better consultants. Coordinator navigates all of this, puts all of these patients on registries. Psychologist, as I was saying, conducts the interview with the family, does the evaluation. We set this up so we could do research with it. So we do a gold standard evaluation with screening measures at the front end, and then using the ADIS, if some of you are familiar, as a structured interview to really get clear-cut diagnoses, which again, I think is a huge value add when you're thinking about what treatments the patient might engage in. The psychiatrist is kind of running alongside, and then the consultation is it's pretty dynamic and fluid as needed from the pediatrician in the community. Next. So this is some analysis that we looked at for 3 cohorts that we've engaged, and you'll see here just some numbers on what we've done with this group. So again, engagement of a pediatrician, we consider them engaged when they do our on-demand modules, when they engage in monthly learning collaboratives, and when they provide a referral. We recognize that people within a practice come on at different times, and I'm yet to write the paper, but I think it needs to be said that within practices, you're going to get your early adopters, you're going to get your late adopters or mid adopters, and you're going to get the over my dead body adopters. So I think it's true across our pediatric practices that we have about 70 to 75% engagement of the providers within a practice, and there's some that just are not there yet, or take a little bit more time, or need to kind of work side by side with one of their colleagues in the practice. I'm not going to dive into the specific details, but these were our 3 groups that we have done analysis on. We've since added new practices. Next step, please. We did some reported outcomes. It's still small N on the second side, but this is a year post MAC. We saw some really nice increases in their perceptions of being able to have access to training and consultation. Also a little bit, more comfort around treatment for anxiety disorders, screening for anxiety disorders, certainly than where they were before. And so I think this just speaks a little bit to the flavor or the qualitative data of our pediatricians feeling a little bit more comfortable and confident now that they have this collaborative care support. Perfect, thank you. This is our network of community therapists that we've cultivated. That there's I think a lot of interesting legs here, research legs, that I can talk a little bit further about, but we've developed this out into 5 regional listservs. As many of you know, with pediatric practices, they might have their list of preferred therapists that, were the people that came around and did a brown bag for them 5 years ago and got themselves on a list in a pediatric office. So we took this and we culled this down, especially in our area, and identified folks that did some level of evidence-based care that we could define, and then figured out their insurance panels. And so effectively, we don't do much that is special outside of we try and identify who has access within a time window to get the patient into care quicker, closer to home. Next, thank you. So these are the patients. Again, this is a sizable subset of our group that we've run some analyses on. So since 2018, this is a group of 696 patients that we referred. What you'll see here is that we do have, I would say, in our pediatric practice, our small practices that we work with, They maybe a bias here is that many of them are accepting commercial insurance plans. So these we only have somewhere around 20. It's actually closer to 30 if you look at our numbers now, percent Medicaid. So being able to serve a public aid population is we still have some room to go and advance our program towards a little bit more equity. But these were the programs and the practices we were starting with. You can see that many had comorbid diagnoses. Many came to us with prior therapy, and some had prior medication management. Clinical outcomes. So at the time of referral, some had active therapy, but then needed more or wanted a different type of therapy because, again, everybody said, maybe I didn't say this already, but everybody says they do cognitive behavioral therapy. But many people actually don't do some of the core elements of cognitive behavioral therapy. For example, exposure treatment for anxiety disorders is often not done, even when looking at people who say they do cognitive behavioral therapy. Many of our patients received new therapy referrals. Some stayed. A good chunk received new medication trials or titration around the med with recommendations from our psychiatrist. Again, all of this is working with the family through the coordinator to kind of get them linked up to the right type of care, helping the pediatrician feel comfortable with the med management as needed, and supporting them along the way, knowing that we've got this base level of information of what's going on. And then I should say this, but it probably doesn't need to be said. We have, because they're engaged in a registry, we also have progress monitoring measures going forward. So we also send out measures to the pediatrician and the family and the therapist as able, as related to their progress on measurement, on metrics related to their diagnosis. Next slide. So this is an example of that. We use the promise measures. We've written a little bit about this and how they compare to some of the legacy measures that are used, but promise holds promise, I think, especially when considering the age range that we were wanting to engage our youth in. For example, like a PHQ-9 really isn't normed below age 11. So we really shouldn't be using that to measure depression in kids that are, 8 or 9. GAD-7 also doesn't have the nice age range that maybe the SCARED does, but promise actually extends down to 5. And so we have to think carefully about our measures. I would also make the same argument about the Vanderbilt, because the Vanderbilt's really only normed for 6 through 12, but people use it beyond that. So we're kind of in a little bit of a bind here and trying to figure out what might be a better measure for our adolescents that have ADHD. But this is an example of what it looks like in our system, and we send it back out in prettier graphs to pediatricians and maybe make suggestions around need for titration, where are we at with therapy, what are the objective goals, and that's kind of the piece that we do. We also, also problematic is that when you go through the evaluation process, there's a good chunk of people that may not want to engage in progress monitoring measures. So there's a drop rate that's important to consider in setting up these programs. Next. Talking a little bit about sustainability and funding. So we were lucky to start with some initial philanthropy, and that really got us going in the hospital system. But we also have we're a hospital system that wants to do mental health and recognizes that we just can't do it all ourselves, and we have to really think about community members, primary care, and even community therapists to kind of engage. I mean, our wait list at last check for outpatient care in our psychiatry program, which is still kind of small, was somewhere between a year and 18 months. And that's generally untenable. So we're trying to, in some ways, through collaborative care, cut off the spigot and treat kids earlier and identify them earlier to make sure that they're getting care when they need it. We've also supported our programs through research funding. We have a Corey grant right now we use the collaborative care model as it's set up to do the assessment and collaboration that we need with our community therapists and community partners to look at effectiveness of anxiety treatment. So this is kind of an exciting way of thinking about collaborative care. It really is set up to do effectiveness trials if you were doing structured interviews. We also do bill for our services. And last year, Illinois turned on pediatric COCM codes. We're working right now to put those within our Epic, because the challenge with COCM, first of all, Medicaid rates, at least in Illinois, are pretty low. So reimbursement sometimes doesn't feel like it's worth it. And then also, you know, it's kind of it can be administratively burdensome if you don't have it built into a system. That's why I'm excited to see the next presentation too, and how they're navigating that, because so health systems, I think, really have to invest in that, do it at least in an early investment. However, it can be very you know, beneficial and provide some really nice cost offset that you just can't get out of the CPT code. So it is probably the path forward. Next up. Oh, I'm always doing a plug for this. One of the things that we did is we really didn't think that there was enough open access material available to train pediatricians. So we were looking around and kept cobbling information together. And we had all of our curriculum and our modules for CMEs for our pediatricians, and then decided, let's just tear it all down and start back over. And so we created a site called RAMP, Resources for Advancing Mental Health in Pediatrics. This is open access, open source material for training pediatricians, includes all of our curriculum. I think the way we move forward in training pediatricians and pediatric care providers is to just give it to them for free. And we kind of make it short. Like, you know, it's wonderful to have our presentations, but it's hard for us to get pediatricians to listen to 20 minutes of a presentation because they are seeing a lot of patients. It's just a unique setting. So with that, I don't think there's any more slides, and I thank you for your time, and sorry that I probably went over 20 minutes.
Thank you. Thank you very much, John. And we'll take a few minutes for questions for John, and then we'll move into Dana and Berna's presentation. So questions for John?
I have a question. I don't know if I get to speak and ask questions. I'm really hoping yes.
Sure.
So I loved this presentation, and I love people being so thoughtful, particularly around pediatric collaborative care. And if you figure out the 11 and up or 14 and up ADHD problem, then please let the world know. A question actually that I was wondering if you've thought about, and I looked at a model recently in New Hampshire, and I love the pediatric models where you have the psychologist folded in. I think where I see it being problematic is one in scale and replication, you know, for other organizations, but two, when you start billing the collaborative care codes, counting that time towards the minutes actually increases the amount of time, and you may or may not get paid for that additional 99494s. Or if you're passing and you're doing commercial insurance, then the amount of time could increase the copays, you know, for patients. And we're saying, wait a minute, there's an hour on here for supervision or whatever the case may be. And so I've wondered if you've thought about that at all, or that's how you intend the model to be, and sort of counting that towards the billable minutes.
Well, you know, I think so. You know, maybe a quick step back here, and I'm not sure I'm going to answer your question directly, because I'm truthfully, we're just starting to get rolling with our build for COCM. And I know enough to be dangerous, so I don't want to hang myself out there on skinny branches around the billing model. But when I think about IPC, or the integrated primary care model, which has typically leveraged psychologists, it's probably the big issue is workforce, right? Psychologists are expensive. They may do things that are a little bit different than training a social worker to do it, because social workers typically have different training models that they're brought up in. More often evident, like longer term care can be a little bit more longer term care. There's less consultation models and really when you're thinking about IPC, it's nice when you are able to do brief interventions in session, in clinic, the day of. And so kind of working towards that, I think, and finding ways to bill for it. It's like some groups are using H&B codes to do that. But it's hard because there's a number of reasons that it's hard. But I do think that integrated systems that have people on site can work in tandem with collaborative care, because what the integrated care systems often miss is the psychiatric consultation. And so, but what collaborative care sometimes misses is how to navigate the psychosocial treatment. So I think we kind of need both, and a lot of the build depends on what the specific primary care setting is able to do. Things, there's still issues like space and navigating billing and who's going to drop the bill. Is it a care manager? I mean, we haven't even talked about the level of training needed to be a care manager, because I mean, in Illinois right now, one of the things we're struggling through is the CMS or Medicare codes don't have a much looser definition of what the behavioral healthcare manager can be.
Yes.
And Medicaid in the state of Illinois demands that it has to be somebody with a bachelor's degree. And truthfully, what we need in a care manager is you need somebody who's got a good clinical backing, but is a good people person and knows how to read measurement-based care and keep detailed information. I don't think you need somebody with like a high-level degree or even potentially a social worker to do the care management, because I don't think social workers always want to do, and hiring social workers is another issue, because it becomes a workforce issue as far as like, how do we, if we want to expand, we're going to have to think a little bit more broadly. So I didn't answer your question, but I went on a riff.
No,
Yeah,
thank
I'd
you.
like to,
Yeah, no, I appreciate it. Thank you.
If I could step in, I want to make sure that we're able to get through Verna and Dana's presentation as well. And I'll note that we see some questions coming up in the chat room. If we're unable to get to them in this session, we'll make sure that we get something out to people. We'll do our best, but I'd like to make sure we have time for Dana and Verna. So with that, Dana and Verna, turn it over to the two of you. Thank you, John.
Great.
Thank you.
Thank you. So really glad to be here. My name is Verna Little, and I'm one of the co-founders for Concert.
Dana, you're on mute.
Oh, Dana's still on mute.
Dana, you're on mute. There.
It wouldn't let me unmute, so I apologize. I'm here now.
You got it now.
Yes, I was restricted, which could be a good thing. I'm Dana. I'm Director of Quality at MedFirst Primary and Urgent Care, and thank you all for joining today.
So just to start a little bit about Concert. So we're a behavioral health medical group. We're actually in 18 states now. We've cared for our 60,000th patient. We have probably closer now to about 200 master's level behavioral health providers and a little over 18, I think we're around 20 board certified psychiatric consultants. And that's a mix of MDs and nurse practitioners, reproductive health, addiction, geriatric, child and adolescent. We partner with some of the smallest organizations in the country. So I think still one of my favorite practices is a one doc practice in Bronx, New York that serves pediatrics, all the way up to some of the largest health systems in the country, Mercy in multiple markets, Advent Health in multiple markets, and super glad to partner with MedFirst in North Carolina. And I'll let Dana tell you a little bit about them.
Thank you, Verna. You can go to the next slide, Sam. Thank you. So we are a hybrid. We're both primary and urgent care. We've got 23 locations. We're subjected to getting 28, hopefully by the end of this year. We're led by Paul and Wes for our CEO and CFO. We've got 300 plus employees and 80 plus providers, whether PRN, full-time, part-time. We have really actually only one pediatrician out of all of ours, so we're mostly adults, but we do see peds, and we are part of the Aledade ACO network, and our Medicaid is our CIN through CCPN.
So when we partnered to do collaborative care, I thought it would be helpful to talk a little bit about what the journey is. We whenever Concert Health partners with an organization, we actually insist on being in the electronic health record. I know for many of you, and I know co-founding Concert Health, one of the things that was super important to me is that no PCP ever went outside the system, their electronic health record, to do anything, and that shouldn't happen, and it doesn't happen. So we take the referrals directly in the EMR. So however the providers make referrals, then we actually take them in the electronic health record based on, the results of a screening, perhaps. They would then say, I work with Verna. She's part of my team. She helps me care for my patients who are sad. I'd love to have her give you a call today. Concert Health provides care virtually, either telephonic or video, and patients have the choice each time. So we try to reach out to them same day, next day, so that we can get them into care, have them go into care with a collaborative care clinician who's a master's level person, opens the episode, begins to care for that patient, generally keeping them in care about 6 to 8 months. Concert Health really swallowed the Kool-Aid in terms of fidelity to collaborative care. So those multiple contacts, early into the episode, in the first couple of weeks, a couple of times a week, following up on that psychiatric consultation, making sure they're getting that specialized psychiatric consultation, giving that information directly in the electronic health record to the primary care provider, and then continuing to work with the practice and the providers, reporting information, metrics, looking for a 50% or 10-point reduction in 90 days and in 120 days, and also provider adoption of collaborative care. Go ahead. So when we think about,
oh no, go ahead.
No,
you go ahead.
Okay. So when we think about how we're engaging and what it looks like to really work with partners, generally try to work with organizations on screening, because we still know, we talked to one of our partners recently, and even though they're screening a couple 100,000 patients, actually what happens to a lot of those screenings is still a little bit in the air. So really making sure we're educating, giving CME and other information out to providers on collaborative care, on psychopharm, really encouraging them to take a population health approach. So it's your entire population of patients with depression and anxiety, not just, I always say, the frosting on the cupcake, the people who, you might think need counseling. Metrics are really important, giving them back to the site leadership, back to the organization, and using that for joint learning with the organization. So Dana, I don't know if you want to add.
Yeah, I mean, just with the engagement strategies and partnering with Concert Health, it was a tool to help support our providers in providing behavioral health to their patients. And so it was a really good partnership. And we just continue with the education and the engagement with Concert Health to make sure that our providers are engaged in the process.
So a little bit about the patients that we're caring for. Concert Health does care for patients 6 and up. So this was a little bit around the breakout for the different ages. So again, you can really see a predominantly sort of middle-aged population, but certainly some pediatrics, adolescents in there as well. Go ahead. Very mixed insurance type. One of the things that is very important is that we can adopt across the entire payer mix. We know that providers are less likely to really engage in a relationship or any kind of a new service if it isn't across their entire payer mix. So really making sure that we do that. This is a little bit around the breakdown. And as you can see, certainly a significant number of Medicaid and Medicare Advantage patients in addition to commercial. One of the things that's near and dear to us, and particularly to me as well, since we started Concert, was understanding that a significant number of the patients seen in primary care are actually at risk for suicide or endorse some suicidal thoughts. So part of what we've done around collaborative care is make sure that our providers have a way to say, oh, you know what, I have someone on my team, let me connect you with them now, so that we can assess them and make sure that they are getting the appropriate level of care, and have seen pretty good success at reducing risk for patients that we care for. Go ahead. So these are some of our improvement rates that we share with the practices and with the site. In terms of the number of patients at 90 days or 120 days taking a baseline PHQ or GAD, and then at 90 days and at 120 days. Go ahead. And these are for anxiety and the GAD. Go ahead. So I don't know, Dana, if you want to talk a little bit about provider satisfaction and patient satisfaction and what we've seen.
Yes, we've had, so when we implemented with Concert Health and kind of partnered, kind of tracking how our, providers are referring and the conversion rate, and then just kind of how satisfied they are. I think having the integration into our EMR was key, and how that worked in the referral process. It has made it very easy for us to refer patients, and then also to get that feedback back. Real time is significant in making it work and making that collaborative partnership.
One of the things we also know is that a lot of times organizations will have concerns about the ability to really adopt collaborative care, provider adoption, the need for a registry. I think the registry is often a concern for practices about being a larger lift. So we certainly did try to make that an easy button. And also, I think staffing, the ability to actually have a solution that will roll across all of the practices and not, so many times I think we hear from organizations, I have a care manager in this practice, but, we're concerned about how we're going to roll that out across all of our other practices and how we're really going to get provider buy-in. And I would say we still struggle, 7 years into Concert Health, around getting providers to really embrace the idea of population health for their patients with depression and anxiety, like they do for their diabetic population, as an example. And so how is it that everybody who scores positive or everybody who's on a medication actually gets collaborative care and the right amount of touches to really make sure we're monitoring symptoms, they're getting some measurement-based care, they have a care plan? And so I think that's something that, we're working on here with MedFirst providers, and continue to work on, sort of across the board. And I know that, Dana, what you've seen in terms of provider buy-in and some of the conversations, maybe share what some of the MedFirst challenges were, as we embarked on this journey, because it is a partnership and, it doesn't go without hiccups, right?
We did. I mean, there were a couple of hiccups, but it was all a learning thing. And it was with communication and making sure and saying, hey, how are we going to do this? And the implementation, we're large, we're multi-site. And so having staggered approaches and kind of implementing at different times and kind of then tracking what those providers are doing and then showing them the results. And just our CEO is also a very big proponent on this, and just really ensuring that our providers are supported, that they have the education tools. We make training available to them. We've done a lot of the monthly engagement training or Q&As, office hours. But we did, we had that little bit of hiccup in the beginning, and we continue to work and clarify what collaborative care is. And providers are starting to kind of get on the bandwagon and starting to understand really what it is and how to refer and the benefits of it. It's a little scary in the beginning. I think any provider would be scared. But I think we're at a good point now, and we're going to continue to kind of branch out and continue our improvement with our providers.
I'd be interested to hear also, one of the big discussions in the field now is, do I grow it, right? Do I grow collaborative care? Do I contract collaborative care? And I'm just wondering, from the beginning, it is a big leap to sort of go into, we like to think of ourselves as clinical partners with an organization. I just interested to hear, we've never talked about, so if people think this is scripted, totally not, what some of your, concerns were in the beginning that maybe would be helpful for people, on the call.
Yeah, a lot of it was probably centered around, integration into our EMR. People are going to be in our EMR. That's always scary. It's good. but that's something that there was, questions around. What is the billing process going to look like? What is the payment going to look like? And how much lift is going to be required? Because we're all stretched thin. Everybody's very stretched thin. And what is the lift going to be? And so it's kind of, those were the things that we looked at. But knowing that, with Concert Health, they've done a great job of just helping with supporting that and saying, okay, we'll try to take a lot of that burden off. Or what ideas do you have to kind of help with this? So that's kind of been really nice, because we wouldn't be able to do it on our own. We can't. We don't have the bandwidth. We don't have the training. We don't have the support pieces. So we love to partner in order to kind of provide this service. So there is work to be done, but it's not impossible, and it's a lot easier than I think people may realize.
There was actually a question in the chat, and we can go to the next slide as well, around the copays. So I know, we have sort of a shared pretty significant commercial population. So, there's a process in place for the copays. So did you think about what, I remember sort of talking about that early on in the relationship. Has that been problematic in any way so far, or any thoughts?
No, the only the way that we have it now, so the copays have actually been really good. I think it's more of, from our system, with patients who might not be paying their bills, is trying to collect that in advance sometimes. So that's kind of maybe just from a practice standpoint, to think about what the policies and procedures are around collecting copays for something like this, because that can be a challenge, but that's a challenge for any virtual type of program. So that's the only thing that we had, or those self-pay rates, and looking at what that could be and what that, and adjusting it as necessary.
Yeah, there's a question in the chat too about, value-based. And I think one of the things we hope is, once we get the airplane flying, so to speak, right? Like it's still taking off, once we get it flying a little better, I think the hope is that, we can actually go into some value-based arrangements or some partnerships with some of the plans. And I know, your role in the organization, you would be front and center for some of those discussions. And I don't know if you want to elaborate on that at all, or any thoughts.
I know we're short on time, but I'll just mention one thing with that is, with behavioral health and the integration with Concert Health, the medication adherence, that's always a big one with value-based care. And so ensuring that patients are adhering to their medication, and not seeking, if they don't need to be going to the ER, because that's not where we want our patients to go for, mental health if they don't have to. So we're really happy that we can kind of serve them where they are. And I think now day and age is, let's meet the patient where they are so they don't overutilize high cost services, and be able to provide that support to them.
Yeah, and this is still a fairly new partnership. So, we have about half of the providers that are sort of actively engaged and continuing to work on that. And we sort of jointly got a letter of support to participate in a PCORI grant around bipolar and PTSD. So we're super excited to be able to bring that. Next slide. So I think a little bit around the dashboard, looking at the levels. We talked about the conversion rate. So in other words, the referrals that were converted into episodes went down. Sometimes we see that because providers will sometimes refer and not do the warm handoff, and sometimes need a little bit of training. So it's hard to tell, but I know the teams were digging into that. And, these are the ebbs and flows and hiccups, I think, when you first start, and then continuing to monitor the referrals by site and by provider. Go ahead. This is just a little bit around how we track some of the referrals, who was enrolled, and sites and providers. And I really do think it's important to track some of these. How many patients decline treatment? Who are they? Are they a particular provider, site, or population? What sites might need some retraining or re-engagement? And so we really look to have better than 80% of the providers referring to collaborative care. Because when you think about the percentage of populations that, are on a provider panel, so I would even like it to be higher. But I think if you were going to give me a low benchmark, I would say that, just based on the question in the chat. So I know we're.
Go ahead. And say this is also, getting this data and being able to dig in on our end to find out what are the barriers for our providers. So that does really help with getting this data to understand what are their barriers and what are the needs.
Go ahead. These are some of the metrics, again, that we track and share. We'll be glad. I know this is getting shared out so people can see them. And I know we'd be glad to answer any questions for people afterwards, particularly people embarking on this journey, a little bit about what we track, how we look at it, how we use it, so that we can see, and particularly provider engagement. Go ahead. And glad to answer any questions in time to spare, Michael.
We have one I'm looking at. What is your target for percent of providers referring to collaborative care? You had an earlier slide on the referrals per month. Do you have a target?
Yeah, I had answered that talking. I mean, we really try for about 80%. I think that's a good, healthy, oftentimes we're, it's a struggle to be able to get there, but I think, given the size of the population that has a behavioral health need on a provider's panel.
Okay. Other questions? We have probably a minute and a half left here. Okay, I'm not seeing any come up yet. We'll see if any pop up, but in the next minute or so, mention a couple of things. First of all, thank you to Verna and Dana, and again to John for presenting today. This was really, really good, and we appreciate everybody who joined the session today for doing so. Thank you for doing that. I will go to the next slide, Sam. It should be the last one. Just a comment, we have our next session coming up on the 29th of September, so roughly a month from now, again 12 to 1. And we have one presentation set up for that. That is from the university, not the university, the Blue Cross Blue Shield of Michigan. Some of you may be familiar with the program that Bill Beecroft and his team have done, the work they've done in Michigan. It's really phenomenal, and they've recently instituted a pediatric collaborative care program. So we've got a bill lined up for the 29th, and we're locking in our second one for the 29th. So if you can join us on the 29th of September, please do that. And let's see, we've got one more question that popped up. What are your financial targets? Revenue to cover expense, care, clinician productivity, etc. So sort of a sustainability related question. Verna,
so Dana, I'll let you take that from the MedFirst side.
I will. So I think our margin is really, I think, anywhere from 13 to 15%, if that's kind of what, to ask what that is. So we bill out the fee, and then we pay Concert Health the agreed upon, but it's about a 15% margin. Does that answer your question?
Well, let's let it answer it for now, given that we're at the top of the hour.
Okay.
And we're happy to take follow-up questions from people. You can email them to where you got the invite from. And again, we will have the video of today's presentations posted on the Mid-Atlantic Path Forward website, which is on the Mental Health Association of Maryland's website. And we'll do our best to follow up with any questions we can answer after this. So thank you all for participating. Thank you again, and have a great weekend all.